I ask Dr. Sagarika, please, to go ahead with the keynote address. Hard, mature, white cataract. FLACS is my choice.
Keynote address. Keynote, second one. Yes. Thank you. Thank you for allowing me to speak. I realize that we are all tired of listening, but just hear me out, because this is something that we all come across. White, mature cataracts, we can't see anything at all. And then along with that, you can't see how hard the cataract is, how hard the nucleus is, and practically you can see nothing at all. The capsule becomes more fragile in these cases, especially if it's a young patient. There'll be leakage. The moment you put something, you'll find that there's leakage of liquefied cortical matter. The capsule just runs, the capsule rhexis just runs to the periphery. There's so much of high intraocular pressure, and there's degeneration sometimes of this anterior capsules. You've got calcium deposits over there. And as I said, you don't know how hard is your nucleus. And remember that whenever you're doing a hard nucleus, you require much greater phaco power, more time. There can also be residual posterior capsular opacification. Now, we all explain to the patient. We give good amount of counseling to the patient. But, the patient's expectations are way beyond what you have reasoned. You have explained, but has the patient really understood? Does he understand that this kind of surgery is not easy? That this kind of surgery is really not what we normally do? Therefore, white cataracts in a young patient have their own special difficulties. And is it the type of surgery we have been performing all the time? Now, the important thing is that we want to give our patient the best and safest and most precise surgery. We all have sleepless nights, especially when we have a young patient. He may be a slight myope. He's got a white cataract. We know all the things that can happen. Will our rhexis split open, run away? Will our cornea, because if it's a hard cataract, cornea remain clear? How much of vision the patient is going to have? Will the cataract also be leathery, so you can't break it, you can't separate it? So many things keeping on and on, troubling your head. And along with that, so your heart rate, your adrenaline, your anxiety levels are all very high. Your hands are trembling when you're doing all normal surgery, which you're practically doing. These are normal things. Absolutely normal. And the unfortunate thing is, add to that is the state of affairs in our country. You do your best for the patient, but the patient is ready to come along and hit you. You wear a coat of armor also, no use. So now you have a dense white cataract, no idea what the capsule, nucleus, the nuclear sclerosis is like. You've done your OCT, now your docking comes. Once you do a nice docking, what do you find? You can come to know by the OCT how hard is your cataract, right? And therefore, you also are able to lessen a decrease of your adrenaline rush by putting the offset in the correct position. And so, And so you have this docking, which gives you a lot more of information. See, we have just reset the posterior offset, and we've come to know that this is not really a hard cataract. This is of a young myope who came along to us with an absolutely white cataract. Therefore, the most important thing, which is the major surgical challenge in these type of patients, is to get an adequately sized continuous CCT. And therefore, we do not want in any circumstance the Argentinian flag sign. And therefore, we say, oh my God, what do we do? So we can conquer this most important step by doing a FLACS. Remember, your dread reflex is also being compromised because of poor visualization of the anterior capsule. And therefore, a particular study has been done in RP Center by Dr. Banathi, etc. Then now they found, you can just see the differences in the capsular rhexis of a FLACS versus a manual one. Mind you that sometimes you may also have tags in a FLACS when you've done a FLACS incision, and the lots of cortical matter is just beneath the anterior capsule, so that also might cause problems to you. So a major source in IOL power calculation is what? Which is the effective lens position, inaccuracy. Now, FLACS produces a more precise, reproducible, better centered, stronger opening in the anterior capsule than the conventional CCC. Mind you, a conventional CCC has a very round rhexis also, because when you're doing a FLACS, you've got small points which you're trying to break off. So therefore, it may be a nice round one which you see, but actually histopathologically, if you look at it, it may not be that round. Along with that, the important thing is you get a very improved overlap of the anterior capsule by the IOL, which produces a less IOL tilt and decentration compared to a manual CCC. So the capsulotomy process is more predictable, consistent size, shape with means of FLACS, but all is not good. FLACS capsulotomy has its own set of problems. You can have incomplete capsulotomy, microadhesions, and you can also have lots of extensions. Now, suppose you've got especially a silicone-filled oil. One case report has been reported in literature where you find that there was an incomplete, here you can show this, see this one, there was an incomplete rhexis, there was also an incomplete fragmentation. So you have to be careful about these things. Now, therefore, you search what are the causes of tears, what kind of preventive measures can you take. So if you find that there's a tilt while you're doing your docking, even a 7.5 degrees tilt is ready that to cause an incomplete capsulotomy pattern. Redock if there's significant tilting. So you have to be careful with the patient from the time one that the patient is there for your FLACS. Extent of eye tilt induced incomplete capsulotomy is usually large, often located in the superior area. All of us find a patient just rotates the eye upward because of Bell's phenomenon. Always try to see that the eye is nice and wet. So give 1 drop of 0.3% sodium hyaluronate on the operated eye to wash away all the ocular secretions. Many of us do not realize that the patient has mebomitis and a lot of secretions are present over there. This facilitates suction before the docking. And also try to squeeze away all the air bubbles and ocular secretions. So this is, again, a very small, I always feel, why not have a wonderful rhexis? Because half your battle is won. And so once you do the rhexis, then whatever method you want to do, you've got a very, very hard cataract, and therefore you can do sculpting, or you can do, and then once you do one sculpting and break one piece, and after that you go ahead and do your chopping, and therefore the pieces of pizza, they just separate out, and how comfortable that is for you. Along with that, with the FLACS, remember there's softening of the hard cataract. That also, therefore, it reduces your phaco time and diminishes also the risk of posterior capsular complications and endothelial injury also. Now, we learn from our masters, and this is none other than from Singapore. The lady says that I would give intravenous mannitol 30 minutes preoperatively, minimize speculum pressure. If capsular fibrosis is present in such a case, I would prefer a FLACS incision. And what if our patient has all the features of diving into complications, but also wants a premium IOL? Now, we want a 5 to 5.5 millimeter perfectly round centered capsule rhexis is a preferred choice for a premium IOLs. So if you've got a right size of capsule rhexis, it completely covers up the optic of the IOLs, lets the IOL center over the visual axis, you get the best visual results. Your patient is happy and you too are happy. So, of course, the capsule rhexis will depend upon different IOLs designs. We're not going into that. The precise size will be customized with femtosecond lasers available, and this also leads to less intraoperative intraocular aberration. We have already talked about the advantage of using FLACS for also up to 1.5 this thing of astigmatism. So that also is good. Now, suppose, let's say, for example, you've done everything, but you get a PCR. Now, therefore, now you've got a perfect rim. You do a little bit of your good vitrectomy, and along with maybe your VR colleague, and then this perfect rim of capsule allows you to place your IOL. Maybe that is a piece IOL over there. Therefore, you don't even need to put a glued IOL or scleral fixated IOL. You get back very good vision, less handling of the eye. Of course, there's less inflammation. Don't forget, all of us have our indemnity bonds over there. I didn't know what an indemnity bond was till I joined the civil. In the army, we don't have indemnity bonds. However, so in tales of, don't forget that there are huge amount of tales of medical negligence, and everyone says we are apathetic. We are not. We try our level best, but there are sometimes when problems occur. Mind you, all of us are not from PGI, where consumer cases against for medical negligence was not taken up against PGI. We belong to corporate hospitals, oblique private hospitals, so we can have the danda on our backs, so we don't know. Mind you, one person got back how much? When 1.2 million, I don't even number of zeros that are there in that million, because of patient being blinded in one eye. So let's not forget that this is a massive problem. So if you and I want to have a good waltz with our patient, let's choose, especially in this type of cases, I don't say in all, in this type of cases, choose the best, safest surgery, and therefore FLACS for such a case. Thank you for your patient hearing.
Thank you, Dr. Sagarika, for enlightening us to use FLACS in these hard mature cataracts. So we close